Thank you everyone for joining us this afternoon. This session will focus on efforts around hepatitis C prevention here in Georgia, discussing the landscape of viral hepatitis statewide, collaborative efforts, linkage to care, and treatment barriers. Today's session will consist of 3 panelists. I will be our first panelist this afternoon. My name is Amy Gandhi. I received my Master of Public Health in 2002 with a concentration in community-based health. I currently serve as the lead for the viral hepatitis epidemiology team at the Georgia Department of Public Health, overseeing viral hepatitis surveillance and prevention efforts. Prior to this role, I served as the viral hepatitis prevention coordinator for the Georgia Department of Public Health for 8 years. In this role, I provided training and technical assistance to public health and private providers, as well as community stakeholders, as well as monitored viral hepatitis vaccination and testing activities throughout the state of Georgia. My prior experience also includes HIV and STD surveillance, prevention, and program planning. Our second panelist will be Ms. Patrice Early. Patrice graduated in 2016 with her Master of Social Work degree, inspired by her family history with substance abuse and her experience as a Black woman raised in an underserved community in Atlanta. Patrice moved on to work in positions where she could support and empower people that use drugs and communities of color. Patrice acknowledges how support and resources provided by others propelled her to move beyond even her own expectations for herself, and this fuels her passion to do the work that she does every day. Patrice currently serves as the manager of the Linkage to Care Department at Atlanta Harm Reduction Coalition. Our final panelist will be Dr. Leslie Miller. Dr. Miller is an associate professor in Emory University's Division of General Medicine and Geriatrics. Her clinical expertise, research, and teaching center around primary care-based hepatitis C screening and treatment in underserved populations. Dr. Miller is the medical director of the Grady Liver Clinic, a primary care-based hepatitis C clinic that provides care for underserved patients with hepatitis C at Grady Memorial Hospital in Atlanta, Georgia. Dr. Miller leads nationally recognized HCV screening and linkage to care programs and lectures broadly on hepatitis C screening, treatment, and alternate models of care. She has been recognized as a hepatitis elimination champion by the Task Force for Global Health. So again, thank you all for joining us this afternoon. I will begin with a presentation around viral hepatitis surveillance and collaborations here in Georgia. Okay, as I mentioned, although the focus of the panel really is to focus on hepatitis C, I'll be sharing a little bit about the landscape of what viral hepatitis looks like here in Georgia around hepatitis A, B, and C. I'll also share a little bit of information on some of the partnerships that we've developed here in Georgia with the Department of Public Health and collaborative partners to address viral hepatitis and their role in hepatitis elimination. So as I mentioned, I'll start with talking about surveillance and what the landscape of viral hepatitis looks like here in Georgia. First, to start off with hepatitis A, as many other states, Georgia has also been experiencing hepatitis A outbreaks since June of 2018. As of August 8th, we've identified 1,217 hepatitis A infections among individuals age ranging from age 3 to 86, with a median age of 45 years. 64% of these cases have been hospitalized, and we've identified 8 deaths with this outbreak. We also have a high rate of co-infections. 2% of our cases that we've identified are co-infected with hepatitis B. 14% have been co-infected with hepatitis C. If you look at the patients that have been co-infected with hepatitis C, 84% of those are in specific areas of the state, specifically in North Georgia, along the Augusta area, along the South Carolina and Eastern Tennessee borders. We've also seen 8% of our cases having been co-infected with HIV. Again, majority of those cases have been in the metro Atlanta area, and primarily among gay and bisexual men. This just shows a bit of a timeline of our outbreak since its start. As I mentioned, the outbreak started in June of 2018. At this time, we had identified a small cluster of infections in central Georgia that were primarily among HIV positive gay and bisexual men. In the fall of 2018, we began seeing increases in North Georgia, primarily in those counties that were bordering Eastern Tennessee. And these cases were primarily driven by illicit drug use, both injection and non-injection drug use. By early 2019, we began seeing increases in the Augusta area, primarily bordering South Carolina. Again, these were also driven by illicit drug use. Around the same time, we also began seeing cases in Metro Atlanta, primarily Fulton County. However, this time, these cases were primarily among gay and bisexual men. In the fall of 2019, we began seeing those cases spread to other counties around Metro Atlanta. However, with outreach and vaccination efforts that we had put in place, we began seeing decreases in all of those areas. However, this past spring, we began seeing increases in other areas of North Georgia, and again in Central Georgia. However, this time in Central Georgia, the cases were being driven by illicit drug use versus gay and bisexual men, which is what we saw at the beginning of this outbreak. Again, although we did see outbreaks among MSM populations, those areas are now shifting, and we're seeing more of those cases being driven by illicit drug use. So here in the Metro Atlanta area, most of our cases now have a drug use risk factor associated with them. So statewide, our primary risk factor is illicit drug use for this outbreak. 54% of our cases have reported illicit drug use. And if you break that down even further, 51% of those cases used injection drugs, 54% used non-injection drugs, 27% reported both injection and non-injection drug use. And for 38% of those cases, we identified that there was illicit drug use. We just weren't able to determine whether or not it was injection or non-injection. Shifting to hepatitis B, we continue to see acute Hep B infections in adults. Typically, we see around 100 to 120 cases per year of new acute hepatitis B infections. Although we did see a sharp increase in those cases in 2018 when we had nearly 180 cases that year identified. Georgia also has a fairly high prevalence of chronic hepatitis B infection. This is primarily because Georgia has a very large foreign-born population as well as a large refugee population in Georgia as well. As far as the demographics of what we're seeing with our acute hepatitis B infections, again, these are the new infections that we're identifying. Our infections are primarily among males, primarily among whites. And you can also see that the primary age group where we've identified acute infections are those adults between ages of 30 and 50 years of age. One thing about our risk factor information with our surveillance data, it is limited. However, I did want to at least point out the increases that we've seen in the past 5 years in acute hepatitis B infections among those that reported illicit drug use within 6 months prior to their diagnosis. We also saw an increase in those that reported as ever using illicit drugs in their lifetime. Okay, so now shifting a little bit towards hepatitis C infections here in Georgia. As many other states have seen, we've seen a steady increase in acute, again, brand new hepatitis C infections between 2013 and 2017. But we did see a decrease in acute infections over the past 2 years. As you may know, acute new Hep C infections are very difficult to identify, as many people don't have infections, or don't have symptoms when they're first infected. So we know that the number of cases that we've identified, that the true burden of acute hepatitis C infections is likely much higher than what we've identified. Here in Georgia, again, as many other states, we also have limited capacity for surveillance around viral hepatitis in general. And we tend to focus on the younger age groups. So we may be seeing a decrease because some of those acute infections may be shifting to older age groups, or it may be a result of decreased testing. It's hard to know what caused that decrease these past 2 years. Georgia also has a high prevalence of chronic Hep C infections. However, you can see in this graph that nearly half of our chronic cases are classified as being probable. What this means is that we don't have an HCV RNA result for those patients. Georgia, as of right now, does not currently require negative lab reporting. So some of these cases may have been tested RNA negative, but we would not have gotten those results. However, we do know from our surveillance efforts that many of our cases, they never have an RNA done. So that kind of shows us a need to continue training providers on the testing recommendations and reflex to RNA testing. As far as our demographics, our acute hepatitis C infections have been primarily among males, but we've also seen an increase among females over the past few years. 78% of our acute infections have been among whites. This graph shows us both acute and chronic infections combined. And as you can see, as expected, majority of our cases are in the 50 to 70-year age group. However, you can also see a steady increase in cases, not only in those cases between the ages of 20 and 30 years old, as well as, but if you look at the age group of those between 30 and 40 years of age, you can also see a sharp increase in that age group as well. As I mentioned with hepatitis B, risk factors for hepatitis C are also very limited due to our capacity to do surveillance in the state of Georgia. But for our acute infections that we've identified over the past 5 years, 27% of them reported injection drug use within 6 months prior to their diagnosis, and 22% reported non-injection drug use within 6 months prior to their diagnosis. Okay, so now that you have a bit of an idea of what viral hepatitis looks like here in Georgia, I wanted to shift now to talk a little bit more about how health departments can and are playing a role in efforts around hepatitis elimination and some of the collaborations that we've put in place at the Georgia Department of Public Health to address viral hepatitis. So what roles do health departments play? So health departments, especially viral hepatitis programs, are key, I believe, in bringing together internal and external partners. Local and state health departments are able to educate communities, offer free or low-cost testing, provide adult vaccinations, link individuals to treatment, mental health, and substance abuse services, coordinate training for providers in testing, diagnosis, and treatment. We're also able to leverage funding to build capacity, both for health department partners as well as our community stakeholders. And we're also able to build partnerships to expand testing, adult vaccinations, and linkage to care efforts. Georgia is fortunate that we have been allotted funding from our state legislature, specifically around hepatitis C testing. And it's a small budget, but what we've been able to do with that is to leverage partnerships that target both vulnerable and at-risk populations. One of these, the earliest partnerships that we were able to develop was with the Atlanta Harm Reduction Coalition, which dates back to 2016. When we began supporting their efforts around hepatitis C testing. At this time, we were supporting rapid point-of-care testing and reflex HCV RNA testing through our state lab. Over the years, we've been, with the testing efforts that Atlanta Harm Reduction has been doing, we've seen anywhere between a 15 to 20% positivity rate. Currently, we're continuing to support HCV RNA testing, and we'll soon also be supporting hepatitis B testing for their Hep C positive clients. And as a result of our efforts around our hepatitis A outbreak, we also were able to leverage Atlanta Harm Reduction's connection with the community and at-risk populations to help develop another partnership between Atlanta Harm Reduction and the Georgia Department of Public Health Immunization Office to provide 317 adult vaccinations. This will include not only vaccinations for hepatitis A and hepatitis B, but also Twinrix, which is combination vaccination, and also vaccines for HPV, flu, pneumovax, and Tdap. Again, through our the Hep C testing funds that have been allocated to us by our state legislature, we've also been able to support some of our health departments and around hepatitis C testing. One of these districts is the North Georgia Health District, which is highlighted in the map. That's the Dalton area. They began rapid point-of-care testing and HCV RNA testing with our support in 2015. However, after starting their testing program, they saw not only the need and the desire for Hep C testing, but they also found that there was a need to have a solution and a way to care for those that had tested positive. So in 2017, they established a low-cost monoinfection treatment program out of the Whitfield County Health Department in Dalton. This low-cost treatment program is available for all patients that are not covered by private health insurance. And the average cost for patients for this program is about $250 to $400. And that cost really covers the lab testing. They're able to utilize patient assistance programs to cover the medication costs. The program is administered by a nurse practitioner through their medical access clinic and assessed for treatment readiness. And then they're case managed by a registered nurse and then medically supervised by a contract physician. Some of the results that we've seen through their treatment program that they've established, since 2017, they've had 59 patients that have applied for the treatment program, with 58 that were accepted for enrollment. However, out of those 58 enrolled, 49 are receiving or have received treatment since its start in 2017. Patients in the program have ranged in age from 24 to 62 years of age, with slightly more males being treated compared to females. As far as treatment options, have included 3 different brands of medications, Mavorite, Harvoni, and Epclusa. 84% of the patients that have been treated in this program had undetectable viral loads at the 4-week mark. And of the 49 patients that began treatment in this program, 47 have completed treatment. 64% have been deemed complete at 12 weeks post-treatment with an undetectable viral load. 16 did not return for post-treatment testing, and one had treatment failure. Another partnership that has been ongoing with the Georgia Department of Public Health Viral Hepatitis Program has been with Imagine Hope Incorporated. Imagine Hope is a consulting agency that had been providing HIV counseling and testing at substance abuse treatment facilities statewide. In 2015, they became a Gilead-focused partner where they integrated Hep C testing. At the start of that program, they were only testing for Hep C at 5 sites. Now in 2020, they have grown up to where they've now integrated Hep C testing at 41 sites. So at these sites, they're providing not only Hep C testing, but linkage to care services. These sites include traditional treatment centers, medically assisted treatment centers, as well as drug courts. As I mentioned, our partnership with Imagine Hope dates back to 2015, where we were able to provide Hep C testing support as part of their focus partnership as well. We've also collaborated with Imagine Hope to provide training to providers around Hep C testing, diagnosis, and treatment. And we're currently in the process of also being able to support not only support for Hep C testing, but also hepatitis B testing, as well as funding to help support their linkage to care efforts. As I just mentioned, we've worked with Imagine Hope to partner and do provider trainings, specifically around hepatitis C testing. And as a direct result of those trainings, they now have 4 medically assisted treatment programs that are now providing Hep C treatment on site. And, you know, to show what effect that's had, as of now, 38 clients through those 4 sites have achieved viral suppression. And there are currently 15 patients that are currently undergoing treatment at those sites. This just shows the distribution of those 41 testing sites that I mentioned that Imagine Hope has integrated hepatitis C screening and linkage to care. It includes 18 traditional sites, 21 medically assisted treatment programs, and 2 drug courts. And you can see that they're located in both urban and suburban areas, rural areas, as well as the Appalachian area of North Georgia. Also to show a little bit of the results from Imagine Hope's Hep C project. As I mentioned, they started this project in April of 2015. So as of March of this year, they've tested nearly 42,000 patients for Hep C antibody. Nearly 11% of those patients did test antibody positive. And you can also see that 99% of those were tested for RNA, Hep C RNA, and of those 7% did test RNA positive. At the medically assisted treatment centers, about 9% of those clients tested RNA positive. 51% were educated and referred to Hep C care, and 27% of those patients have been successfully linked to care. You know, that percentage may not sound very high, but also remembering that Hep C treatment providers are scarce and limited in the state of Georgia, especially for those that are uninsured, those that are in rural areas of the state. So the fact that they've been able to successfully link 27% of their cases to care is worth noting. I also want to note of the antibody screening that Imagine Hope has done, about a quarter of that testing was supported through our partnership, their partnership with the Georgia Department of Public Health viral hepatitis program. And again, I just want to thank you all again for joining us this afternoon. If you have any questions, we're happy to answer them later, or my email was also at the beginning of this slide set if you have questions after. Thank you. Okay, next, our panelist this afternoon will be Patrice Early. Patrice?
Okay. Thank you, Amy. All right, good afternoon, everyone. I will be talking about approaches to hepatitis C care today. All right, so general housekeeping. So the slides of the presentation will be sent to everyone who registered at the end of the presentation. All right, so I am Patrice Early. I'm a social worker and the Linkage to Care and Counseling Manager at the Atlanta Harm Reduction Coalition. So I oversee programs under that fall under Linkage to Care, including our Linkage to Care for hepatitis C related care. All right. So a brief overview of hepatitis C. We're gonna do, here's the brief outline of the presentation that's gonna take place today. So we'll do a brief overview of hepatitis C prevention and linkage to care at AHRQ. We'll discuss the values that inform our service delivery. We'll discuss some prevention initiatives. We will discuss how our other departments, such as our Connected Care Clinic, as well as our prevention department, our syringe services department, all kind of collaborate to provide care to the community, and talk a little bit more about the Linkage to Care department and our services. Okay, so here at AHRQ, we help by identifying individual level barriers and connecting clients to the best care available in the city of Atlanta, including those at our own agency. Some of the services that we provide include strength-based care management, linkage to medical care, including HIV and hepatitis C related care, linkage to substance use counseling, linkage to mental health counseling, assistance with obtaining furniture through the Atlanta Furniture Bank, temporary and long-term housing referral assistance. So we don't have funding to directly provide assistance with housing. However, we do refer out to various community partners that do have those resources. We assist with accessing food, assistance with transportation, which I'll discuss a little bit more later. And we have an integrated treatment team approach to care management, so utilizing our social workers, our case managers, and our clinic team. All right, so some of our values. Healthcare is not exclusive to medical care. Healthcare includes having access to quality housing, food, and social support. Social activities such as sex and drug use should not deter access to quality care. We understand that clients are the experts in their lives and have a right to self-determination. We are here to educate and provide support for people. Our approach to care management includes presenting clients with options that support harm reduction. We do this by providing and researching resources that aim to reduce undesirable consequences that could be associated with drug use and sexual activities while upholding the dignity and worth of the person. We are very big on a person-centered approach, utilizing person-first language and experiences to inform our work. Intersections of race, socioeconomic status, and gender all play a role in people's experience with accessing care. So we value and recognize those intersections, and dismantling the stigma that prevents people from accessing the care they deserve is what we aim to do. All right, so a little bit about prevention. So our prevention team goes out into the community to various different sites, and they provide on-site rapid point of care testing, and that's testing at no cost to the community and the participants that engage. And a component of that prevention effort is the educational part. There's pre and post-test counseling that's offered. There's a brief risk assessment whereby the participants are able to engage in conversations with the prevention specialist and receive some supportive tools. Promise stories. So that's an intervention that we use. Promise is a CDC intervention, and we utilize it to highlight people's personal stories. So sometimes we'll interview clients who don't mind sharing their personal story and experience with living with hepatitis C. So they'll start off by, talking about some behaviors they may have engaged in, their experience with, leading them up to getting in care, or whether or not they're, still learning and still going through the process. And so this is, an intervention we use to empower the clients themselves. We maintain their anonymity. However, they are able to share their stories. And their goal is usually to spread awareness to the community and hope to prevent people from contracting HIV or hepatitis C, as well as promote services. You know, they share their experience, they went on to get treatment, and so hopefully by sharing their experience, they will motivate someone else to do the same thing. Community education services, so collaborating with different partners in the community to provide harm reduction education as well. Peer engagement, utilizing peers and members of the community, again, to inform our services, listen to them, and gathering their experiences to really, you know, teach us more about the work that we do. Outreach. Outreach can be in the form of, you know, going out and providing food to the community, education, testing. And so we try to incorporate all of those initiatives into our outreach efforts. And the baseline of it is really building community, building relationships with the people in the community to build that foundation of trust. Condom distribution, we distribute condoms in the community as well. We also have them at the office, they're free of charge. People can come by and grab those things. In addition to that, we also distribute hygiene kits. So sometimes our promise stories are contained in hygiene kits and condom packets, whereby people that can make use of those items are able to take advantage of that. We offer warm handoff services as well. So if our prevention team, they're out in the community and they encounter someone that has a rapid point of care test, they will connect them with the linkage team. And sometimes that may be them actively coming into the office with the client to do the warm handoff instead of just sending them on their way. This is just to maintain that relationship building and, you know, to let them know that we're here for them and they're not just going to be shuffled to the next place with no clue what to do or who they're going to be in contact with. All right, SSP, our syringe services program. SSP is instrumental in relationship building with clients. Syringe access itself is crucial to treatment as well as prevention. Our SSP team have been in the community. The clients know them, they love them. Oftentimes it's clients stopping by, even if they're not accessing services, they will stop by to let them know how their day is going, how things are going for them. And this is important for us because as we, the linkage team, may come in, we're not just strangers coming in. You know, they already have a relationship with our SSP, and so we're able to leverage that and, you know, use that as a sort of segue, you know, for us to come in. We are partners. We work together. They're a part of the agency. They're not a part of the SSP, but they are part of who we are. They do the same work and have the same goals as us. And so that kind of eases that transition to having the client see us in the linkage to care department. And so SSP helps reduce barriers to client engagement and retention. If clients are apprehensive or they don't want to come down to the office, we can go to them. We get in our cars, we drive to Syringe Exchange, we can meet them there. It's a place that sometimes they feel safer. They're more familiar with it, and we're okay with that. We try to work around that and make it happen. Volunteers. Our volunteers are an essential function of our SSP. They come and they do wound care, they bring food, and sometimes they just bring good vibes and laughter, which is also very important in that relationship building with clients. All right, so our syringe services program takes place 3 days a week. So Monday and Wednesday, we are in the English Avenue / the Bluff area, and on Sundays, we are in Little 5 Points. And that information is here. If there are ever any questions about SSP, you all can feel free to reach out and contact us at the office. All right, so our Connected Care Clinic. We are very, very excited and grateful that we have our clinic and we're continuing to build. We have wonderful providers. We have a medical staff that includes 2 medical assistants, Nakia Campbell, Eternity Franks, and our providers, Kate Newman, Shante Walker, Dr. Kalapila. We are very grateful for the services that they've been able to provide. Through both the clinic and linkage, we have been able to work with different partners in the community to remove barriers for clients. Northside Hospital has a program where we're able to refer clients to where if they can't afford imaging and those higher level of care needs that we can't provide. If they're eligible, they can get those services for free. So that's very instrumental. Being able to refer clients to Grady and Piedmont Hospital are also very, very beneficial to us. And so through our Connected Care Clinic, clients are also able to get additional medical services, including testing, screening for STDs, HIV, and other treatment. And just being able to see a provider. You know, sometimes we like to rewrite the narrative. If clients have had some type of adverse experience with a provider, we come in as providers. So essentially we're kind of the same like as those experiences. So we try to rewrite that narrative a little bit. So even if they aren't ready to engage in hepatitis C related care, we're able to meet some of those other needs as well and build those relationships. All right, our SAFE program. So SAFE program is an acronym. SAFE is an acronym. It stands for safety. We like to provide a safe space. Advocacy, we like to give clients the freedom to choose, and we always want to empower our clients. And SAFE is the overarching program whereby clients can access the medical care and the care management and case management. Clients are offered one-on-one education sessions with linkage specialists. They're able to sit down with us and for one, you know, talk about this, you know, possibly new diagnoses or where they are in their life. If they've known their status for a while, you know, what do things look like now? How can we assist you with navigating this space by providing resources and just, you know, emotional support? Care management, if there are other barriers to care, right? Because so many other things can come along with accessing care, housing, food. We try to assist them with accessing those resources as well. And linkage to our Connected Care Clinic. When we encounter a client, we try to walk them through the process of getting connected with the medical component of it. If they need an ID, making sure we can provide a referral to get an ID, things of that nature. Transportation services. So pre-COVID, we were offering warm transport services. So we use our own cars and transport clients to their appointments. Prior to having our C3 clinic, we would take clients, we would refer them out a lot more. And so we would, you know, take them there if that was a need and accompany them to those appointments. All right. So we understand that, you know, clients are educators, right? They're the experts in their own experience. They're the ones that are leading this process. We're here to learn from them just as much as they are able to learn from us. Medication adherence support. So we try to provide different interventions to ensure medication adherence. And, you know, sometimes it's knowing that a client may not be ready. So if a client is accessing an assistance program for their medication, they could only access that once sometimes. So it may be better to, you know, sit back and assess these other scenarios that may play a part in whether they're adherent to their treatment regimen or not, and remove those barriers and address those barriers first before engaging them in treatment. Their decision to put off treatment doesn't exclude them from programs and services. They're still able to take advantage of our case management services. The transportation, whether it be taking them by car, utilizing our Lyft services program, or providing a MARTA card, we try to provide those services to remove that barrier. Linkage to other supportive services, looking at the other social determinants of health and seeing how we can address those by partnering and referring out to other community partners. And engagement in other programs and services, encountering people who may not have known we had a syringe exchange service, connecting them with our drop-in center to ensure that they, you know, have a hot meal, engaging them in some of the groups that we have on site. And so, you know, looking at the person sort of holistically is what we try to do to see what how we can achieve the best outcome for that individual. Oops, go back one. All right, so some barriers to care include misinformation, requirements of higher levels of care. Sometimes clients, you know, they need imaging, they need liver scans and things like that that we are not able to offer, so we'll refer them out for those things. I'm fine, I'll do it later. You know, if I'm having, you know, other things that I need to address, I feel okay. You know, I know that tonight I may not have, you know, something to eat. That's something that I'm experiencing right now. Health-wise, I feel fine, even though I'm living with this. So, you know, sometimes there's a need to address those other things before we get into that medical care. Housing is healthcare. Lack of adequate housing, that is crucial. You know, it's hard to expect that a person can adhere to a medication regimen when they don't, you know, have those resources, a place to even store their medication. Co-occurring conditions, mental health conditions, medical, housing, and food insecurity are all sometimes barriers that need to be addressed first before engaging a person and expecting retention and care. And COVID-19, of course, has been a huge barrier and has certainly pushed us to be a bit more creative with how we're able to engage with the clients. And so exploring, you know, utilizing our tents and our mobile health unit more out in the community, utilizing Lyft to be able to provide the transportation services is certainly some of the things that we've been trying to do, allowing clients to get their mail at our office if they need to do that, are some of the ways that we've been trying to address some of the barriers related to COVID-19. All right, so our Linkage to Care department is open. You guys can come see us or call us Monday, Tuesday, and Wednesday from 10 to 5, Thursday 11 to 6, and Friday from 10 to 4. We will be at 1231 Joseph E. Boone Boulevard. We do have a schedule difference now. We have some people working in the office and someone working at home, but if you call or come by, you should always be able to see someone within that window period. And again, these slides will be available at the end of the presentation to everyone that registered. And I would like to turn it over to Dr. Leslie Miller.
Great, thanks so much. I will just pull my slides up. Okay, so those are two great talks. I'm really happy to be able to round it out and talk about HCV microelimination at the Grady Liver Clinic. And so this is just really an example of how one health system is addressing the hepatitis C epidemic and how we can get one step closer to elimination. Let me just... Okay, so here are my disclosures. So I want to just start by giving some background on Grady Health System and then specifically on our liver clinic, and then we'll look at some screening and treatment outcomes. So just to give you kind of a broad overview of Grady Health System, it's a big, busy, wonderful place. So we have 640,000 patient visits a year. We have close to 1,000 inpatient beds. We also have a network of 6 neighborhood health centers in addition to the main hospital downtown. Grady has more than 6,000 employees. And fun fact is that a quarter of all Georgia physicians received some training at Grady. I am one of those. So to kind of focus now on the Grady Liver Clinic, we're a nationally recognized innovative model for hepatitis C care. We were established way back in 2002 before we had great treatments for hepatitis C. And now we really have a goal for microelimination at Grady. So the thing that's unique about the liver clinic is that it's primary care based and generalist run. So traditionally, hepatitis C care has been done by hepatologists way back, and then more recently infectious disease providers. But we kind of got into this in the early 2000s as general internists, thinking that, you know, we could take this on as well. And it's been a really successful model and has really allowed access to care for those who couldn't seek that specialist care in the past. So I really want to focus on kind of two aspects of what we do at the liver clinic. So one thing is we serve as a linkage venue for screening programs. So we kind of administer the screening throughout the health system. And then we also serve as the landing place for those who get screened and are positive. So we provide critical access to care and treatment for un- and underinsured patients, again, who might not have the ability to access care elsewhere. And then another thing we do that's kind of an extra added bonus, but is really, you know, had a ripple effect really throughout this state, I think, is that we train future generations of HCV providers. So we have, you'll see in a later slide, all kinds of learners who rotate through. We have clinical pharmacists as part of our team. They have pharmacy students and residents who rotate through. So people who kind of pass through the clinic get some Hep C treatment experience and really can take that with them when they leave training. Okay, so I mentioned we're going to focus on screening and treatment, and I thought this would be helpful to look at the gaps in the HCV care cascade. And you guys have probably seen similar graphs before, and this is just a sample cascade where you see that, if this were a sample 100 people who were HCV infected, only about half of people with HCV are tested and aware of their infection with antibody, and then only about half of those are confirmed with RNA testing to confirm chronic infection. And the numbers just go down from there. Only 17 out of the 100 are linked to care, 15 treated, and 9 cured. And I kind of doctored this up with all these arrows just to show you. So kind of the two major intervention points, and what we'll be focusing on are the screening piece. So if we intervene at the HCV antibody testing phase, and then also at the treatment phase, we can really improve this entire care cascade. And I feel like intervening on the screening side, if we can antibody test people, especially if we have programs like reflex RNA testing, which Amy mentioned and which we have at Grady, we can get the RNA tested equal to the antibody tested, and then, programs that have linkage to care built in, which many screening programs do, we can kind of get all those bars up to the same level in one fell swoop. And then if we address the second part of the cascade that has a big gap, which is treatment, once we intervene on treatment, the medications do the rest for us, right? So we have medications with 95 to 98% cure rates. So if we can get folks treated, we're pretty much going to get them cured. So I feel like if we focus on those two areas with the arrows, we can really improve this entire care cascade. And those are the areas we're focused on at Grady. So why is screening so important for microelimination? Like I said, only half of people with hepatitis C know that they have it. And this is a really important time in 2020 to be talking about screening, because both the CDC and the US Preventative Services Task Force just came out with new screening recommendations. So where previously the screening was focused on baby boomers and those with risk factors, I've kind of adjusted this, this cool infographic from HepView. Really now the recommendation is to screen all adults, so universal screening. So the CDC says anyone 18 and over, the USPSTF puts a cap at age 79, but pretty much all adults are due for screening now. So this is especially important. If we screen more people, hopefully we'll get that other half that isn't diagnosed and into care. So let's kind of take it close to home and talk about how we've implemented screening at Grady and how this has really affected our elimination efforts. So this is sort of a timeline from 2012 when we started screening to present. So we first started with CDC funding when they came out with their baby boomer screening recommendation back in 2012. And we started just in one small part of the health system in one primary care clinic. And that was successful. So in 2015, we became focus partners and we expanded our screening. So we expanded to Grady's network of neighborhood health centers. And, we continue to uncover a high prevalence rate, which I'll show you guys in a minute. And so each kind of successive area we went to screen, we kept finding high prevalence, and that was motivation to continue to expand our reach. So in 2017, we expanded to the inpatient service, which has really, been eye-opening in terms of a really high prevalence area that we weren't reaching before. In 2018, we expanded to Grady's specialty clinic, so medical subspecialties throughout the health system. And then in 2019, we expanded to the walk-in clinic and emergency department. And I'd say, I don't have it on this timeline, but the biggest thing for 2020, and this has been a challenge in the setting of COVID, obviously, but we did launch universal screening when the CDC and USPSTF recommendations came out, and that was the end of April this year. So how do we get folks screened? We know that providers are unreliable to do this ourselves. We have a lot of other competing priorities. We forget things sometimes. So we really wanted to make an electronic health record based approach so that we could, make it as easy for providers as possible. So this is just a sample of our prompts. So we basically have an algorithm that runs in the background that informs these prompts and fires for anybody who meets screening criteria. So prior to this year, it was anyone who was a baby boomer and didn't have a prior test on file. This would fire at triage, and the triage provider would do an opt-out offer for the test and then place the order if the patient agreed for the provider to sign. I just want to point out here that The order used to be just a HCV antibody. Once we implemented reflex RNA testing in 2018, the linked order automatically switched to the HCV antibody with reflex to HCV RNA. So that's our outpatient prompt. And then inpatient, we added this in 2017, like I said, to the general order set for inpatient orders for all med surg patients. So basically, and we kind of bundled this with HIV testing as well. So this automatically fired if the patient met criteria, and then the provider would have to kind of uncheck it if the patient disagreed or opted out. I do want to point out that the kind of logic that informs whether this fires, we changed it this year with universal screening. So now this fires for all adults 18 to 79 years old. Okay, so that's kind of how we implemented it and what have been the outcomes. So this is our timeline from when we started with our focus program in 2015 and up through July of this year. And so you can see we've tested over 45,000 individuals, and we have a really high prevalence, 8.5%. It's interesting because this varies by setting. So our inpatient prevalence is as high as 14%, and outpatient is more like 6 and 7%. So the average overall is 8.5%. We were able to test 87% for HCV RNA. If you look at just our numbers post reflex implementation, it's really close to 100%, but this kind of covers the whole spectrum of time from before we were reflex testing to including reflex testing. 58% of our patients who are tested for RNA are viremic, meaning they have chronic HCV infection, and then we've been able to link 69% to care. And a lot of the, that's a pretty high linkage number for HCV screening programs, and a lot of it is due to the fact that we have this on-site liver clinic where folks can land. Okay, so speaking of the liver clinic, we'll kind of talk in detail about that now. So the goals of the liver clinic are to provide access to comprehensive care for underserved patients with hepatitis C. It's called the liver clinic really just to protect patients' privacy when they check in, so they don't have to state their diagnosis, but really we really just treat hepatitis C, not all liver diseases. We also evaluate comorbidities and assess readiness for hepatitis C treatment, and then finally initiate and monitor patients on antiviral therapy. And I'd say, when the clinic started in 2002, many patients weren't treatment candidates due to comorbidities and the toxicities of the medications we used then. But now, really almost everybody is a treatment candidate. So this is sort of the growth and expansion over the years. And I know, folks from AHRC and Amy have sort of witnessed this over the years since we've been working together. But really the biggest change came in 2011 when we got our first generation direct acting antiviral medication. So that allowed many more people to become treatment candidates. And then baby boomer screening, when we launched that in 2012, now all of a sudden we had all these new folks who were diagnosed who, obviously had hepatitis C for a while, but hadn't been screened, so didn't know they were infected. And those folks kind of fed into the clinic and allowed some expansion. In 2013, we got our second generation, our newer generation of antivirals, which were much safer and easier to tolerate. So now all of a sudden, we had lots of new patients screened and lots of patients, almost anybody could be treated. So my lights are going off. Okay, so that really, again, contributed to growth. And then based on all of this influx into the clinic of new patients and new treatments, we really needed to grow. So we had an investment of resources from Grady in 2017 that include a staffing expansion, and I'll go over kind of the roles of folks in our clinic in a second. And then with the reflex RNA testing, like I mentioned, we were able to confirm many more diagnoses, again, feeding more into the clinic. Okay, so I mentioned the staff. So when I first started doing this, there really weren't staff. It was kind of like me seeing patients. And, there we had a few providers. We only had clinic like 1 to 2 half days a week. But now we really have a robust program. So we have 6 general medicine faculty who are all experienced and trained in Hep C management. And then if you kind of go down the left-hand column here, these are our physician providers. So we have fellows who are in academic hospital, and we have learners and trainees rotating through. So we have gastroenterology fellows, infectious disease fellows, addiction medicine fellows, all rotate through and get to experience Hep C treatment. We have internal medicine residents, and then we also have CDC volunteers who, do viral hepatitis work on kind of the epidemiology side, but are also physicians and, get some of their clinical practice with us. So that's a really nice synergy. We have 2 clinical pharmacist specialists who are experts in hepatitis C management. And we, in 2017, were able to hire a nurse practitioner who all she does is hepatitis C. We offer FibroScans for our patients, which is a method of liver fibrosis or scarring staging. And she does our FibroScans for us. And then on the administrative side, we have a program manager, a patient navigator, just for the liver clinic. We use, our general primary care staff. So we run out of the primary care clinic. So we have an LPN and a CMA, and then we have a patient assistance analyst. This is a really important role. She's a pharmacy tech, and she really takes care of all the prior authorizations and patient assistance program applications for our treatment program. And just to put faces to positions, this is our awesome team, and it's just a pleasure to work with all of these folks. So we're really happy to have them. So just in terms of the services we're able to provide, and again, we really focus on treatment, but a lot goes into that. So we do a lot of counseling. A lot of folks, when they're diagnosed, really don't know anything about hepatitis C. And so we spend a lot of time doing education and counseling. We provide vaccination. So we test everybody for hepatitis A and B and vaccinate those who are susceptible. And then patients with cirrhosis need additional vaccination. So influenza, pneumococcal vaccine. So we take care of that as well. As I mentioned, we do fibrosis staging. So that's kind of multi-component, but the FibroScan is a big part of that. We can do imaging, so CT, ultrasound, MRI. We do lab work that can also contribute to the fibrosis staging as well. And then kind of by default, about 25%, I would say, of our patients with Hep C already have cirrhosis by the time they get diagnosed. So, we do a lot of cirrhosis management as well. So making sure folks are up to date on their liver cancer surveillance, which involves imaging of their liver every 6 months. And if they need screening for esophageal varices, we, refer them for that as well. So this is kind of the sequence of how things go in the liver clinic when somebody has an HCV diagnosis, and that means they're confirmed with antibody and RNA. And this has changed a bit with COVID. So the first step is liver clinic education. And we used to do that in a group session for outpatients. And then for inpatients, actually, we decided what worked best was for a navigator to go directly to the bedside, or for the ED as well. The navigator would go straight to the bedside when somebody was tested positive in the ED. Obviously, with COVID, we had to change all of that. So we don't have group education classes anymore, but we're still able to do phone education. So it's more on a one-on-one over the phone as opposed to a group in-person setting. But we still feel like education is a really important component. And then from the education, they get their first liver clinic visit. We've made some changes with COVID as well. We are doing a lot of telehealth right now. So patients don't necessarily have to come in person for this visit. Oftentimes they already have all the workup they need. And even at the first visit, we're able to refer to treatment. We want to make it as easy and streamlined for patients as possible. So if they have all their testing done and they're ready to go at the first visit, we can go ahead and refer them for treatment. Oftentimes we need additional studies like imaging, additional labs. So sometimes it takes a second visit, but rarely more than that. And then we have navigation kind of throughout this whole process, really to support patients through and make sure, they get to the next step that they need. And this is just a quick synopsis of our workup. So kind of what happens and what tests do we do once patients are diagnosed. So anyone who's confirmed RNA positive, genotype testing we've traditionally done, and I think this will become obsolete hopefully pretty soon. We have multiple pan-genotypic regimens, meaning they treat all genotypes. It's still required for some payers, so we still have to do it on occasion, but I think this will be phased out relatively soon. I mentioned we test people for hepatitis A and B. We also test everybody for HIV. We do treat patients with co-infection, but we just want to, know they're co-infected before we get into treatment. We do their liver fibrosis assessment. And then the nice thing about doing this as general internists is we're used to dealing with comorbidities like diabetes and hypertension and kidney disease and different medications like statins for cholesterol that may interact with their Hep C drugs. So we kind of do all of that, and the clinical pharmacists are absolutely key in helping us with that drug-drug interaction piece of it. So we kind of wrap all of this information together and come up with a medication choice, and then we go ahead and refer for treatment. So this is just an array of all the different medications we use, and really the point is just there are multiple things to choose from, most are 1 pill daily, 8 to 12 week regimens. And you can see across the board, SVR means sustained virologic response or cure. And cure rates are, like I said, 95 to 98% across the board. And they're really well tolerated. So unlike using interferon, which we used to do in the old days that had tons of side effects, there are very few contraindications to using these medications, and we're able to treat most folks. So I just want to highlight, and this is, I think maybe we all try to look for any silver linings we can in this era of COVID, but this is really one that's come out of the program since the pandemic started. And this is just to show you what our on-treatment sequence was before COVID. So we would rely pretty heavily on in-person visits. We actually provide the medication to the patient at the clinic, so they don't need to deal with the pharmacy. We kind of coordinate everything with our central pharmacy at Grady, and then are able to bring the medications up to their clinic visit. So we would do blood work at each visit. They would meet in person with a clinical pharmacist and get their medication, and that would happen every 4 weeks. So there would be like a treatment initiation visit, a week 4 visit, a week 8 visit. This is for a 12-week regimen. And then we would just tell folks to come back in 3 months after they finished for their HCV RNA for test of cure, and then follow that up by phone. And you can see how we were able to streamline this. And I got to update the slide and take out a lot of icons and text. So we were really forced to do this when our clinic kind of went to all telehealth during COVID. And the thing that's really nice is that this coincided with a simplified treatment guidelines by the AASLD and IDSA that came out in late 2019, which really allowed for much less in-person monitoring and less need for blood work during treatment. So we were able to simplify this. We're actually able to courier medications out to patients. So for treatment start, they can opt for either an in-person or a telehealth visit. We can courier their meds to them. And then at week 4, they just get a phone visit. We send medications again. And then this is just a sample of an 8-week regimen. They're done at 8 weeks, and then they come in 3 months later and get their SVR12 lab work done. So that's been really successful, and I think it's super patient-centered, and patients are really responding well to it. I just wanted to address specifically, how people who inject drugs kind of interface with our clinic, and sort of what our strategies are to really try to include this population. It's a really important population to aggressively seek out and treat if we're going to achieve HCV elimination. So I think years ago, the mantra was, folks had to be clean of all substances for 6 months prior to treatment. And that went out the window several years ago. And I think, that message is still around in some places, and we're really trying to dispel that. So we have absolutely no kind of substance use prohibitions around Hep C treatment. You can be, drinking, you can be using, and it doesn't mean you're not a Hep C treatment candidate. So in terms of identifying folks, I think the universal screening has been really helpful for that, because, it's no longer just baby boomers. We know that by just screening baby boomers, we're missing a lot of this population. And so now hopefully we'll be able to capture this population a little bit better. I just wanted to stress, and I do this with all of my learners, that there's a really strong body of evidence, and you guys know this, that supports good outcomes, excellent outcomes with DAA treatment, our antiviral treatment for folks who are injecting drugs or folks with substance use disorder. So there's no reason or justification not to treat. But we really need to be creative with outreach strategies. And some of those include partnering with agencies who serve people who inject drugs, like AHRC. And then I put linking linkers here. So, I think we all kind of have navigators, and making sure the navigators connect with each other and know each other. And that's been really helpful to kind of get clients to the right place and where they need to be. Adapting clinic protocols has been really important for us. So I mentioned we have no barriers to treatment that we impose. Now I will say sometimes payers impose those barriers, and we, appeal them and try to get around them. And we've been successful in doing that. And so that is sort of the strategy there. So I just wanted to just show you really quick kind of over the years how our treatment outcomes have progressed. So when we first started doing this, you can see all the way on the left in 2002 to 2007. So this was in the interferon era. We really treated very few people. I think there's a missing number there, but it's supposed to be about 20 people. Really low treatment numbers and really low cure rates. And you can see over the years with new therapies, we've really had high cure rates and high numbers on treatment. So we treat about anywhere from 400 to 500 a year now. And cure rates, above 95%. So in terms of the program impact, again, we're really focused now on microelimination at the health system. So routine screening has led to significant numbers who are aware of their HCV status, and our treatment program has resulted in thousands of cures over the years. And the other piece that we're really passionate about is spreading the model, so adapting it and spreading it throughout the state to different providers. So, one of my favorite things to do is to do trainings and, just to kind of share my enthusiasm for this and makes folks realize that not only is it relatively straightforward and easy to do, but it's so satisfying and rewarding to be able to, help patients get through a cure for their chronic disease. So I've done trainings for the Department of Public Health, different hospital systems, and SUD treatment clinics. And so, I think any one person who kind of gets trained up and can treat Hep C, we're really expanding the network, and that's what we need to do to eliminate Hep C. So I want to stop there and thank you and look forward to taking questions.